Hello, everyone, and welcome to this latest installment of ALNAP's Urban Webinar Series. Thanks for making the time to join us today. We're going to have a great hour and a half with some really excellent and far more experienced colleagues than I to share their experiences of the Ebola response in urban areas and hopefully draw out some learning for future urban humanitarian responses. My name is Leah Campbell, and I am a Senior Research Officer here at ALNAP, and I'll be both chairing and presenting in today's webinar. In a few minutes, I'm going to tell you a bit about our panelists today, but before I do that, we wanted to start off by asking who's on the line with us today. And so we're going to launch a poll in a moment that you can fill out while you listen to me describe who our panelists are today. There's a few different options to tell us a bit about how much experience you, our audience, have with the Ebola response, and this will help our panelists gauge how much you know about the topic already. We're just having a technical issue with the poll, which seems to now be closed, but hopefully we can get it back up in a moment. So I'll get started with the panelist bios, and hopefully we can get that poll back open again. Okay, so our three panelists today are the following. We have Fernando Fernandez, who is a physician with a master's in public health and a focus in healthcare management. Besides his work on healthcare systems, he's been working in different humanitarian contexts for organizations like Merlin, WHO, and ICRC. And he now works for the Directorate General of Civil Protection and Humanitarian Aid Operations at the European Union, ECHO. And he went with them, with ECHO, to Sierra Leone during the Ebola response. We also have with us Helen Seeger, who is now a reporting consultant at the IOM, writing and editing reports on global migration and displacement as part of the Displacement Tracking Matrix team. She's been supporting humanitarian response work in various countries since 2008, including responses in Pakistan, Yemen, Nepal, Turkey, and Lebanon, so all very urban crises there. And in 2015, Helen was deployed to Sierra Leone by Plan UK and managed a large-scale project supporting quarantined homes in various areas. And our final panelist today is Rania Elessawi, who has more than 18 years professional experience in international development, applying a human rights-based approach and results-based programming, from planning to implementation in development as well as humanitarian contexts. One of her key areas of focus and strengths has been working on building collaborative partnerships with civil society organizations, including faith-based organizations, as well as private sector organizations, media, advocating with them and leveraging or mobilizing resources to support behavior change interventions through program implementation with UNICEF and its government partners. And this was particularly instrumental for the social mobilization and community engagement pillars of the response during the recent West Africa Ebola outbreak, in which she worked in Liberia throughout the first declaration of the country to be Ebola-free. So those are our three panelists. We also have a special guest star who I'll get to a moment after the poll is open, is closed rather, who is Philippe Decourt, who was also involved in the Ebola response, and he's going to tell you a bit more about that. Philippe is now the director in charge of the New York office of UN Habitat and has a long history that I could not possibly summarize into a paragraph about his urban response. So we are going to close the poll now, and I believe that'll pop up the results for us on screen. So we have a little bit of a mishmash of you, but by and large, over half of you have read a little bit about the response, but were not involved in the response. So you're kind of like me. So that's good to know, but we do have a few of you who were actively involved or had some involvement, whether in rural areas or through short-term deployments and HQ responses. And for those of you I guess on both sides, if you have experiences to share, if there's something from your response that you were involved in that you'd like to share, you can use the chat functionality the questions function rather, throughout the webinar to share your own experiences, and I can certainly relay those wherever possible as they fit into the discussion. And for those who either responded or didn't, or have lots of questions and less answers, that is the functionality for you to use as well. You can ask questions at any point during the webinar, and then we'll save them all up for the end session. I'm going to turn to Philippe in just a moment. After we hear from Philippe, we're going to go through 4 different rounds of me sharing a little bit of the content from the papers that ALNAP has produced, capturing learning from the urban aspects of the response, and then hearing from a few of our panelists. And then at the end, we'll have about half an hour, hopefully, for questions and answers, some of which were submitted in advance when you registered, and also any that you share with us live in the webinar today. So I'm going to turn now to Philippe, who's going to share some thoughts on how he got involved with UNMIR. And so we're going to turn now to Philippe.
Hi everybody, I hope I can be, you can hear me loud and clear. Good morning from New York. So I was part of Human Habitats at the time already, and we've been in Human Habitat for about 15 years. And we got this request exactly for urban expertise to be seconded to the UN Ebola mission. I was the one that had made the case for it, so I was volunteered to go. And the agreement quite quickly was, when I got to Accra, was to focus on Monrovia. We were talking end of September 2014. Things had escalated drastically, and there was a clear sense that the fact that the virus had gotten into the urban areas was the main reason for it, but nobody really knew what it meant and what it meant also for the response. So the question was quite simple. I had no experience in dealing with these kind of diseases, did some quick research, and clearly there wasn't a lot to start from. I was lucky that I ended up in Monrovia, because the representative of UNMIR there, Peter Graaf, I think was very clued in and basically said, look, figure it out and tell me how we can adapt a response to deal with the urban nature of the Ebola crisis. I attended one of the first big coordination meetings, and one thing which was very clear: everybody was in the room, the big donors, the ministries, the key organizations, about 60, 70 people in the room, but looking at the screen of Liberia as a country, indicating the number of cases in the last weeks and how things were moving forward. But for me, of course, as an urban expert, the thing that struck me, there was a very dark red dot on Monrovia. But the discussions were being held, which was representing 50% of the cases at the time. But all the discussions were focusing more on the country level, and not really trying to pay attention to deal with Monrovia differently from the other counties throughout Liberia. So the first question was, what is happening within Monrovia? What is the breakdown of what is happening, and where is it happening? Which neighborhoods, and why in those neighborhoods? There was no data available, so the first thing exactly was to try to get some data that was allowing to break it down and understand the dynamics across the city. It took me a while to find somebody in CDC, the American Center for Disease Control, that basically in his spare time was linking some of the data he was collecting from the treatment centers to the kind of neighborhood map of Monrovia. So I worked with him to kind of make that map. At the same time, I had received from the Bureau of Statistics kind of a breakdown of the areas of origin in the different neighborhoods in Monrovia, and particularly the slums. And it was very clear, there was a clear link between where cases were emerging and people's areas of origin. And in Monrovia at the time, more than 50% of the people were not born in Monrovia. It's a very important point because looking into it, Monrovia, of course, has quite a high degree of slums that were created mostly after the Civil War, where people from the countrysides and further had arrived in Monrovia seeking safety and basically had never left. Were not giving access to proper land, so ended up in slums and fueling the growth of slums with very bad conditions, sanitation-wise, very high density, but very importantly, very high degree of mistrust with the government. And one point in case was West Point, which was the famous slum that had been quarantined by the army shortly before, had resulted in violence and quite a number of deaths as people were trying to revolt and break out of the quarantine. And I came across an article in the New York Times where they were interviewing Musaka Fala. Musaka Fala was a doctor trained in the US, but basically had spent his first years in West Point in the slums. And the article was describing how he was trying to recreate some of the coping mechanisms that existed at the end of the Civil War. And he was basically saying, look, even West Point as a slum, it's 7 different communities, 7 different backgrounds, 7 different links with different areas, 7 different sets of behaviors based on their cultural profile, the way they were handling the dead, for instance, and took care of the sick. And he basically said, look, it's important to understand the diversity, and it's important also to build mechanisms of communication, of engaging these communities, take into account their particular nature. And for me, I quickly met Musaka, and that's, I mean, for me, it was the main start of coming up with a more tailored approach to the crisis. The main point, and of course, I came across Rania, who's going to speak next, in UNICEF. How do we change communication? How do we change some of the key components of the response, specifically tailor them to the urban area? Going back to the first meeting, the main absent of the meeting was the mayor of Monrovia. None of the mayors of Greater Monrovia was at the table, and I went to ask her, why are you not there? And the answer was very simple and disappointing. She was not giving a role. She was not listened to. And so she spent her time, my time is better spent going out to communities, going out to markets, going out to the bus stations, going out to the different neighborhoods to engage community members directly. And she was mobilizing community leaders from the different neighborhoods into her municipality, into the city hall, and trying to exactly get them organized and exchange also experiences from the different neighborhoods. So we ended up, after a couple of weeks, arguing and making a proposal to decentralize the response to Monrovia, give it the same level of authority to agree on how to do things, bring the mayor to the table, but also exactly tailor communication, tailor tracing mechanisms, adapt how you deal with the debt to the specific context of the city of Monrovia. And for me, that was the great breakthrough that we managed to obtain after a month. And I'm very much looking forward to the more detailed analysis that ALNAP and Leah led in the aftermath, and also hearing more from the other colleagues on the call. And I'll leave it at that for the moment. Over.
Great. Thanks so much, Philippe. That was such a useful overview, and also a kind of visual kind of idea, concept for those of us who weren't there in the response to start thinking about things. So we have a slide that has the 4 different papers. I'll just point out at the beginning to kind of reference, as Philippe mentioned. So where this came from is that Philippe, after being seconded to UNMIR, to send us a message as we're in touch. He's a member of our urban response community of practice, and had this idea. So we really have Philippe to credit for putting this idea in our heads, that there was something urban and important to capture from the response, and that there was both some urban challenges, but there was also starting to be an actual urban response to this crisis. And so that's where the idea came from, to put together a subgroup of our urban response community of practice, which eventually turned into these 4 learning papers, which if you haven't already seen, you certainly should. The 4th one that's on the right-hand side there actually includes a longer version of a kind of case study story on West Point, which is the informal settlement that Philippe was mentioning there in Monrovia. So we'll start off in talking about the first area that we're going to talk about today, which is communication and engagement. And I'm just going to give a few brief reflections that came out of this piece of work around this topic. So the first thing is around different notions of community. And what we found when we did this research is that humanitarians really struggled to respond overall to the scale of the challenge during the Ebola response. And in particular, this is often because of the kind of atomized nature of community and diversity among the stakeholders that were there. So it was harder to use traditional approaches to communication and engagement. You know, in urban contexts, which are full of social and economic as well as spatial connections, this idea of kind of a geographically bound neighborhood as a kind of default community just isn't everything. It doesn't give you the whole story. People might more closely identify with their cultural or faith group, with their work colleagues, which are not located nearby where they live, with friends and families spread out over a wide area, even outside the city. And so these different sorts of communities require different forms of communication and engagement in order to be effective. The second point I wanted to make around this topic is also about kind of the diversity of stakeholders, specifically thinking about the kind of authority and leadership which might exist in an urban environment. And Philippe there was talking about the mayor in West Point. You know, there's in an urban area, there's so many different organizations and groups that might be representative of one another or not. And whereas perhaps in a rural setting, you might be able to more easily identify and start to work with existing community structures, it's really hard to identify and understand what those might be in an urban environment. And this was certainly the case in the cities affected by Ebola. And so the learning here is around the need to work with a range of stakeholders, including religious and traditional and cultural and government actors. And while this can be a challenge in terms of decision making and knowing who to go to about what, and also coordinating perhaps a larger degree of relationships and different kinds of relationships, it's also an opportunity because it implies, you know, the ability to access local knowledge, build ownership and local acceptance. And to do this, humanitarians need to try and understand better the relationships between stakeholders and also to consider local cultural dynamics. In particular, in the EVD response, it seemed like there was, you know, quite a long history of tension between government and population that was an important dynamic to be aware of because it shaped many of the situations that came up in the response, including the degree to which people would accept the messages and orders that came from government, and that was important to understand. And the last area is around messaging. We found that particularly early on in the response, where a lot of energy was put into informing communities, despite a lot of the information that was distributed afterwards, people were saying that although they got that core message that Ebola existed, could be transmitted, they had more questions of more depth that they didn't know what to do with. The messaging kind of was a bit too perhaps basic and didn't meet the needs and realities that they were kind of confronting, such as what to do with those people who were already infected. And because of the initial communication being oftentimes dramatic or negative, you know, Ebola kills, there is no cure, don't touch people, these messages were scary, and so they often had the unintended effect of motivating to people to stay away from healthcare because, you know, if there's nothing we can do about it, why, you know, why go into a clinical environment? Why not stay home with family around? And some of the messages also were a bit clinical, and they weren't understood by communities or made unreasonable demands that people just, you know, completely avoid touching anybody or using any public transport, but at the same time requiring that people take the ill to treatment units. So these approaches both created confusion and also panic, and sometimes in some cases people hid their sick relatives, which in the early stages really disguised the true extent of the response. And while many humanitarians recognized the huge amount of misinformation, they perhaps did not effectively understand how this had been spread or how to stop it at its source. So those are a few points that came out from the the research we did around this topic of communication and engagement. And I'm going to turn to our first panelist, Rania, to share her own experiences relating to this. So take it away, Rania.
Okay, thank you so much, Leah, and it's wonderful to hear Philippe again on a webinar on this, and it brings back so many memories as well. So what I'll just start with saying, because I don't also want to reiterate so much that you've already spoken so well about, and Philippe as well, I think one of the things that was right at the crux of this response in particular was Ebola was not going to be tackled or stopped if people did not change their behaviors. And that put communication right at the core. And communication to whom was the biggest issue, because it had to stop among the populations. So how did we then focus in on how do we try to understand what do we mean by community? And then how does community engagement evolve, and how social mobilization evolved? And right at the center of that, or the heart of that, was that whatever we did, whatever we communicated, we needed to build trust. And I think that you spoke very well about this, talking about the range of stakeholders that became involved. Because one of the things is that not only are communities just not cohesive, they also have very intense and complex power and social structures. So, and urban communities bring even more challenges because it's even more diverse and even more dense. So what would be our entry points that therefore within communities? Because communities were trying to take action to protect themselves. Of course, within that, there are varying degrees in capacity and knowledge amongst the different stakeholders and people, because information, as you mentioned, fear and what was happening, and people could see their loved ones and family members and friends dying in the streets. Ebola was touching everybody. So how did we tackle that fear of it was so intense right in front of them? What would people be able to do for themselves? And what would be, you know, the triggers for action amongst the communities? Like what could we do, or what kind of information could be provided to communities so that they would be motivated to be able to take their own actions? And how would that process of efficacy evolve? Because that power of everybody collectively addressing, stopping Ebola, and knowing how to stop Ebola and protecting themselves and their families. But not only that, that if they knew someone that did get infected, how did they begin to also evolve an understanding of what they can actually do? That if someone got infected, that they can actually seek help. And of course, there were multiple also variables and factors that infected communities would get quarantined, and as Philippe mentioned, what happened in West Point. So there were so many different scenarios, especially within an urban context, that needed to be taken into account. So as he rightly mentioned, in the beginning, it was very strictly, heavily driven by the Ministry of Health, because our traditional mechanisms of community engagement, or the interfaces with communities, was through health workers or extension workers or whoever were linked to the health system that would interact with communities. And particularly in the urban settings in Monrovia in particular, I'll focus on that, there were different divisions within the Ministry of Health that were involved in the response. So one was the Community Health Department, which had its structure of community health workers. And then there was a Health Promotion Department, which were more program managers that would talk about the messaging and the information. So UNICEF particularly brought some value in that, in where we were coordinating a social mobilization structure. So and beginning to be able to organize who would we engage with, what were the relationships amongst those different stakeholders, but critically in that was who did communities trust the most. And I'd like to just speak about one specific dimension that happened during the Ebola response as well, is the engagement of anthropologists. One that we did, the UN did work with a lot, was Juliet, and Juliet Bedford was actually contributing to these papers as well. And then the linkage with networks of anthropologists to be able to understand community dynamics and the different dimensions within the community. Who was the most influential in decision making? If people were to trust information coming from a specific source, who would they trust? Is it their community leader? Is it their elected representative? Is it their health worker? And then among all of those different groups, how did we ensure that they all receive the same information, and so that to enhance that reassurance that if the message is the same and the information is the same, people would understand what they would need to do in the event that someone they knew got Ebola, or how to prevent it from being transmitted. So so that was a major dimension, to be able to really understand the community dynamics, so that when we planned the community engagement intervention, there was a synergy amongst the different stakeholders that were interacting with the community, and that facilitated entry into the community. Because at the beginning, I think there was a lot of scrambling and, you know, let's just get information out. And if there was a new issue that came up, okay, what kind of message can we provide? But it wasn't so much the messaging, it was who was delivering the message. And I think that that is very critical to keep in mind, whether it is at the rural level, but especially at the urban level, because over there you also have multiple sources of communication, media that come in, social media, radio, access to, you know, national TV. And so the information comes from so many sources, and so do rumors. So how communities would be able to respond to that, understand it, critically process it, and be able to continue to protect themselves. And because Philippe picked up on this, and I wanted to just elaborate a little bit more on it, because one of the critical areas henceforth was beyond just engaging the Ministry of Health, what were other ministries or other administrative structures or governance structures? So he mentioned the city councils of Monrovia and Painesville, and we also developed a partnership with them to engage those community leaders that Philippe talked about and mentioned, to train them as well, so that they can also support the health workers within the communities, because they were trusted, either elected or natural leaders within the communities. So having them also on board really made that push to be able to build that trust with the communities and trust the system a bit more and the information that was coming to them. And that's it. Thank you.
Great. No, thanks for that. And I'm glad you brought up the anthropologist, because certainly that was something that I found really interesting. It's the first time I've seen that group of specialty being brought into a response, and I think it was so critical for this one. So thanks for sharing that, and also giving some specific examples to illuminate my more general comments. We're also going to turn to Helen next and get her thoughts on the same topic. Helen, go ahead.
Thanks very much. I wanted to talk a little bit from a programmatic perspective about how we approached communication to adjust and tailor our programming specifically for the urban context. So as Leah mentioned in the intro, I was managing a project that was distributing food packages to quarantine homes. And also, as the response went on, we started decontaminating houses that had had a sick patient or a body removed, and getting rid of people's mattresses and any other soft furnishings, and decontaminating latrines to make the home safe for the people who were still living there. So we had a standard package, a food package that had been developed early on in the response in the east of the country, in Kailaun and Kenema, in a more rural context. But as it moved to the urban area and Freetown, we didn't have much information about how appropriate it was still going to be once we were there in a different scenario. And these were not normal food distributions as we might see in humanitarian responses all over the world. The aim was to provide people weekly packages with everything that they needed so that they didn't leave quarantine. That was the ultimate aim. So quite different from providing the core staples or starches or proteins that people would then top up on their own. So for us, the key thing was how could we listen to people and gather feedback in a real-time kind of ongoing basis that was fast enough for us to adjust our programmatic and our programmatic approach and our food packages, but also the process of decontamination. How could we tell if it was working, and if not, how could we find out fast enough how to adjust? And one of the opportunities that the urban context provided was the fact that we knew from the knowledge, attitudes and practice surveys that cell phone usage in Freetown was much higher than in other parts of the country. We also knew from Plan's existing work that youth were a big resource, and we had some ongoing work with youth who were generally very tech savvy, very enthusiastic, and relatively time rich compared to maybe older or younger people. So we tried to engage both technology and also these youth resources to do a range of activities, but mostly focusing around SMS surveys, also youth reporters, but also connecting those using those youth reporters to connect to parts of the community that weren't perhaps quite so tech savvy, to overcome some of the bias in use of technology, to include people who didn't themselves have mobile phones. So we actually got a lot of very useful information that way that helped us to, for example, find out that people were breaking quarantine because we didn't put chili powder in our packages, and something as small as including chili powder made a big difference. That the rice we were providing was not the right kind, and various other things that we used to improve the response. We were really able to gather a lot of data about the fact that the water and sanitation situation in the quarantine was abysmal, and we used that data to advocate very strongly for more attention to be put from WASH partners onto sanitation and water efforts under quarantine. So that was something we were able to do because of the urban context that worked quite well.
Great, thanks, Helen, and thanks for starting to lead us into the next topic as well, which is quarantine. And I wanted to say at the start of this that this issue of quarantine might sound like quite a unique issue that probably doesn't come up in a lot of humanitarian crises. But a lot of the learning, actually, I think, that comes out around working in this context of quarantine is really about issues that do come up in other urban crises, And so I wanted to point out a few things about governance, about coordination, about the kind of logistics of working in kind of such extreme density, all of which I think you will find relevant for future urban crises. So on governance, in the Ebola-affected countries in West Africa, the decisions around quarantine are made by the government, and in some cases quarantine was enacted at the household level and made a lot of sense, and in others it was used as a measure of social control rather than perhaps a public health sound medical decision. And in all three of the affected countries, with the government taking leading roles in the response and the involvement, then there was quite a lot of involvement of different layers of government, which is, I think, what Rania and Philippe were getting at in terms of the lots of the different ministries involved and different layers. And all that, and understanding, how decisions are being made and who is the right layer or person to speak to is a lot more common in an urban environment, particularly in capital cities. And I don't know really how much effort was put into understanding the political context and using this to kind of support perhaps advocacy around quarantine, because the research didn't end up finding much examples of this, but that doesn't necessarily mean that there wasn't action on this by humanitarians. It was just it's a very a topic we just didn't get to in the research. So that would be perhaps interesting to see if anyone has any thoughts on that. In terms of coordination, in order to be effective as a measure of reducing the risk of transmission, quarantine households needed to actually remain quarantined and be there and be willing to stay in their house all day and every day in the required period. And this is why the interventions that Helen was just talking to you about now were so important, because without access to food and water for drinking and bathing and assistance with decontaminating their belongings and so on, it wouldn't be possible for quarantine households to comply with the quarantine order. And even things like, as Helen was mentioning, that the spices needed or the food that they actually wanted to eat. If someone says you have to stay in your house, and I'll give you some food, but it's not food you like, then I'm still going to leave my house and go and get what I need. And so the understanding of this was really important, and as was the coordination, because people weren't quarantined necessarily in a nice orderly group or row or on the same kind of time scale. Each day new households were added to quarantine lists, and these were located over a vast area. So really the work that was done to coordinate the various organizations providing support to quarantine households over the area was also important because of the cost of gaps and also the cost of duplication that could lead to even more transmission. And the final area is around this context of density, kind of navigating these informal settlements, which are really perhaps best highlighted by this issue, because the close proximity between dwellings, shared water and sanitation facilities really challenged whether quarantine was possible to even enforce. And it also had huge logistical considerations for those trying to respond, even in other situations where you have density, you can get close and have people come to a central distribution point. In this case, people had to get these large quantities of items across a dense area, in some cases without any roads and only pathways to access each household, for the people who could not leave that house. So that's a huge logistical challenge of density. And I know that that some of our panelists were involved in doing this sort of response, so perhaps they'll have some light to shed on this. So I'll turn first to Fernando to hear his thoughts about how to navigate this kind of context of quarantine and similar situations in future urban responses.
Okay, thank you, Leah. Thank you very much. First, good morning, good day to everybody. First of all, I'd like to encourage people to read the very nice documents that you have made, which I think summarize a lot and very well a lot of the issues that we encounter in this response, and particularly the aspects of the implications of a response in an urban setting versus the typical response that we would have in a rural setting. Now, quarantine is one of those examples. In previous outbreaks, typically the authorities will put under quarantine the whole affected area, surrounded by army or whatever, in making the whole area in that sense already isolated. This is not something, though sometimes they try, this is not something that could be done in West Africa for many reasons. Which may not be relevant to enter now, but what clearly says is that it is not something that you could normally do in an urban setting, as the case described from West Point very clearly, very well explains. The first thing I would like to say about quarantine is that it is always a desperate measure. It is a measure of last resort when we cannot control an epidemic with other tools, with other things. Sometimes authorities need to resort to the quarantine. But then the authorities have to be humble enough to also acknowledge that in their communication. They have to explain to the people that this is not the first choice. This is because they cannot do anything else, because they are overwhelmed with the situation. And that will help to build a little bit the trust and to buy the compliance a little bit of the population. Unfortunately, it was not always the case. Then, as per WHO recommendations of the group of experts who came after the Ebola outbreak, as we said, but the rationale for quarantine should always be made very explicit and understandable to the population. The people at the level, they need to understand why quarantine is important and why is quarantine put on them, so that they can know how to comply with this quarantine. And if these explanations are not given, then it's going to be very difficult to implement it, even if you try to enforce it with police, army, or whatever. I mean, people will not respect it, and it will not be very useful. Which is critical, because the quarantine has, as your document very clearly explains, has a lot of problems. There's violation of human rights. There are plenty of issues. There is Yakuza principles that have to be followed. But most important of all, it's going to break a lot of social consensus. It's going to create a lot of unrest among the population. If on top of that it's not effective, then what's the point? No? So in order to make it effective, one of the things is that the rationale to put on the quarantine should be very clearly explained to the population. And when that rationale is gone, it's over, it no longer applies, then the quarantine should be removed. And if it has to be continued for some other rationale, then the new rationale has to be explained to the population. Otherwise, people will lose confidence and will not respect it. The other thing is that which is very important, is that when you're putting the quarantine, for us, very clearly coming from the humanitarians, as you very well mentioned, this was not suggested or imposed from the humanitarians. This was coming clearly from the health authorities. At least the case of Sierra Leone, it was coming from the authorities very clearly. But one thing that we need to remind constantly is that if you're going to put in place quarantine measures, you still need to respect the human dignity of those people who are put on the quarantine. And that means a lot of things, but it means, to start with, it means that you need to make sure that at least the basic needs are covered. This may sound like very evident, but it was not always very clearly understood. I mean, these people will still need to eat every day, but they will also need water every day. And that was, when they start putting these quarantine measures, it was not always well thought by the authorities or understood. And the people who are going to be put in quarantine, as I said, they need to be informed, and they're probably going to need some sort of extra psychosocial support so that they can cope with it. Something like the food, when you put quarantine in a rural setting, well, people normally have store food in their houses because of the crops, because of whatever, so they're used to live at least a few days with the food they're stored. But in an urban setting, a lot of people need to buy the food on a daily basis. I mean, that was valid in West Africa, but it would be valid in most cities. I mean, people don't store food for days in their houses. So very often you put them in quarantine, they don't have time to go and buy the food. So all of a sudden they cannot leave. Second, they don't have the food in the house. Very often they don't even have the cash to buy the food. So you need to think on how to bring the daily needs of food to these people, but also the daily needs of water. And that has a lot of logistic implications and problems. Another thing which was critical when it comes to informing the people is, and we spoke about communication, how that was critical. People need to understand the disease that we're talking about, how it can be transmitted, what can they do within their house to ensure that or the area where they are quarantined, that other people do not get infected. How can they protect those who don't get the disease still, or who still don't have the disease, from those who could have it? And these communication campaigns, needed in the case of West Africa was critical and very difficult. They need to fight a lot against a lot of misconceptions, a lot of rumors. There were a lot of vested interests spreading false rumors and false interpretations for whatever, for political reasons, for whatever reasons. But the truth is that that is affecting the campaign, because the messages do not, the really important message and the actual public health message do not necessarily get clear to the people. Then another difference I would highlight between urban and rural is that ideally you need a certain collaboration and certain commitment from the communities that are going to go into quarantine. Otherwise, it will not work. The ideal quarantine will be some sort of self-isolation. It may be difficult to get to that extreme, but clearly you need some commitment, some collaboration from them. Now, that is normally a little bit easier in rural areas, but it's very difficult in urban areas because of the way the communities are composed. Because the people they're not necessarily families among themselves like in rural areas. They don't necessarily have the same idea of belonging to a community. So making them get together into such a difficult decision of isolation in urban areas is much more difficult. Not to mention that among the urban areas, and it has been mentioned before, when it comes to diseases, typically those more at risk are the slums, are what we like to call informal settlements, that are the poorest areas, the one with less services. The areas where typically the newcomers first, when they settle into the city, that's the first place they go to, until they settle down in some other areas. And where normally there is worse, if any, services. We saw this in West Africa. I mean, the slums we're talking about, they didn't have almost any service, and people needed to go and fetch the water on a daily basis every time they wanted to drink. So how can you put people in isolation if you don't bring them the waters that they need to drink? So it's very, very tricky part that we need to be taken into account. And to finish, I would like to make maybe two reflections on this quarantine in urban settings. One is that because of this, the way these people live and these slums and so densely populated, in cities, it might be necessary to think more about putting people under quarantine in some sort of facility rather than in their own homes. First of all, because what they call home very often is a very limited space with a lot of people around and sharing a very tiny space. Of course, this has cost implications, and this have a lot of other consequences. But when, as I said, quarantine is a desperate measure. So if you really want to resort to these type of things, maybe you need to think on a way that at least it's effective. Otherwise, you try to implement, you impose a quarantine, but it's not going to be respected. And the other thing is that for the people who are put on the quarantine, people coming from these slums and these areas, those people, they normally do not have savings or capacity, and they depend, these people tend to depend on a daily income to ensure that they eat. So this is one of the things that may need to be taken into account, is that it's not only providing these people with the basic needs, it's also ensuring that these people get their daily income without having to leave the area where they're supposed to be quarantined. Otherwise, again, people will have to go and find their daily needs. They will not respect the quarantine. And I will leave it here and pass it over to you.
Great, thanks, Fernando, and thanks all of our panelists so far. You know, I'm seeing the linkages between all of the various comments come together, and we've certainly got a ton of questions that have been coming in.